A very good evening to all. Thank you very much, Geeta ma'am, for that very, very kind introduction. And it's my first time with the API. It's indeed a very proud privilege and honor to be addressing because medicine is my first love. My first teachers, whoever taught me anything in clinical medicine, are from the Department of Internal Medicine. I think of them with great respect and gratitude. And my husband is a neurologist. He's been a physician for so long before he took up neurology. So API has been, I mean, it's been like family. I've attended meetings as a family member. So as Madam said, the task which has been entrusted to me is to discuss about the various skin manifestations of systemic diseases and also other things which as physicians you might be probably you might have read about them, might have not seeing them daily, so might have missed them. It's a very I don't know how, in a time of 1 hour, how I could do justice to this very vast subject. I'll try to keep it practical, and I've tried to put together whatever came to my mind. So if you have any queries, if I know it, I'll try to answer them as well. I might have missed many things, like Madam talked about syndromes. I've not put much syndromes here because I thought that might be too boring and not practical. There are a few mentions here and there, but if you feel that there is more clarity needed, please feel free to ask me. I'll share whatever I know, if I know. I'm sure many of you know much better than me, much more things than me regarding the systemic diseases, but the skin part, I'll be definitely happy to shed some light if I know it. So without wasting much time, I'll go forward. Okay, so before I begin, let's start with something very simple. So this is just to know what you see and what is your view. Supposing two patients walk into your OPD and both of them have skin lesions. Okay, and so one patient looks like this on the left hand side, and the other looks like this. I hope the visuals are clear because I'm going to talk a lot with pictures because I can't put in too much theory. So it'll be more of pictures talking. So what I want to ask you is, which one would worry you more? The one on the left or the one on the right? Right. Everybody right. Nobody thinks left. 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 Okay. So could you tell me why would you no, or rather, what do you think would be the one on the left? It looks like psoriasis, right? You have erythema, erythematous scaly plaques, and it looks like a very, very generalized psoriasis. Of course, there are differential diagnoses, but the one on the right is an ulcer, which we don't know what the etiology is. So generally what happens is in dermatology, we generally look at the things which are very dramatic, but in dermatology, what is loud may not be, it is often less dangerous, and what is subtle can be quite catastrophic. So in this was a case of psoriasis which we could manage quite easily because we have all the wherewithal to manage psoriasis, whereas the one on the right turned out to be a medium vessel vasculitis, which gave us a lot of sleepless nights, us, the medicine department, the rheumatology department. So the point that I wanted to make is nothing but that skin is not just an organ that you look at. It is an organ that reveals. Okay, so skin is often the earliest visible sign of systemic disease, as we all know. And if we miss that, we don't just miss a rash, we miss an important window to something deeper, which is why we are here, I guess. We are talking about skin and systemic disease. So I'll cluster a few dermatoses that you often see, which are relevant to you. And the first cluster, the first group that I'll be talking about is the red rash trap. Red rash is, I guess, what you often see. So what are the kind of red rashes that you come across? First is a red rash on the limbs. Any first thoughts about the diagnosis? If no, I'll go ahead with a bit of history, a bit of clinical, because we need that. Now, this is uh, actually lipodermatosclerosis because this has been a long-standing condition. And you can see cobblestoning. You can see bilaterally thickened cobblestone plaques. And if you see carefully, you can... do I have a pointer? If you look carefully, You can also see an erosion here near to the medial malleolus. Can you see? Can you see here? Now the point why I put this slide is because, yeah, I guess if we could switch off the lights, that'd be better. The most important question that we should ask here is the duration. Was it an acute presentation, subacute presentation, or a chronic presentation? In this case, I've already put the diagnosis there. It's a chronic presentation. But why I put this slide is because this presentation is often mistaken as cellulitis. And we often, often they are subjected to antibiotics, which could be quite unnecessary in this case. This is a classical case of lipodermatosclerosis, which you know is associated with venous stasis, where there is a panicula. If you take a biopsy, it's not just a stasis dermatitis. Stasis dermatitis is just eczema. You get scaling, you get itching, sometimes you get erosions. When you get lipodermatosclerosis, it's not the typical not just the champagne bottle appearance that you get. You get a typical presentation, which is very common like this. There is paniculitis, there is induration, there can be pain. It can mimic a cellulitis, but this is not cellulitis. You see the cobblestoning, you look at the duration, and that is the point that and the most important thing is bilateral cellulitis is almost never cellulitis. So unnecessary antibiotics should be avoided. And if in doubt, you can always do further investigations. Yeah, so the data says that at least 20% of patients who have been given a diagnosis of cellulitis do not actually have cellulitis. So most of the IV antibiotics are unnecessary, and bilateral cellulitis gives you a clue that it's almost never cellulitis. So what are the pseudocellulitis conditions? One is, we talked about stasis dermatitis, we talked about lipodermatosclerosis. There is also pigmented purpuric dermatosis. There are vasculopathies, which can all mimic a comes with a red leg, which is indurated, which is tender. There might be some elevated, because the signs of inflammation might be there. Doesn't mean it is cellulitis. So now let's look at any thoughts on this? This is also sometimes mistaken as it's actually a spotter. If you are the slides visible? Okay, thanks. Symmetrically, you can see almost purpuric spots distributed. This is the duration is chronic, no pain, no tenderness, no inflammation, chronic duration, purpuric spots distributed on the legs. Very, very common presentation. This is what we call pigmented purpuric dermatosis or Schamberg disease. Schamberg disease or pigmented purpuric dermatosis. What is it? It's just a capillaritis. Because of chronic standing, because of venous stasis, the small capillaries, they get inflamed and the hemosiderin leaks out and gets deposited there. So what happens, if you see this picture, you might mistake it to be a vasculitis, because you're seeing purpura. You put a glass slide, you will see it's purpura. It's not erythema. It won't blanch. So you think it's purpura, and then you might go unnecessarily think for further investigations. It's a very, very common presentation, especially in people who stand for a long time, in teachers, in people who work. So this is called pigmented PPD, pigmented purpuric dermatosis or Schamberg's disease. You just need to reassure them and send them, and probably try to see if there's venous stasis, which could worsen the process, or avoid long-term standing. Maybe give some vitamin C for capillary strengthening, or pentoxifillin has been reported to be sometimes effective, but mainly reassure them. Nothing much to be done. It is not vasculitis, it is not cellulitis, it is nothing catastrophic. So this is another pseudocellulitis condition called pigmented purpuric dermatosis. Now the next, I think this, I kept it just for, this was a case which was little perplexing. Here again, this was being treated as cellulitis for long. Again, red swollen leg with tenderness. The duration was 2 months. But if you see here, there is almost a pudy orange-like appearance. And it was stony hard. you don't see this much of hardening in cellulitis. In cellulitis, you see some edema is there in the dermal tissues, in the deeper tissues, but stony hard you don't see. This was stony hard, okay? And this swelling was not limited to the limbs, it was also there on the upper limbs and on the abdomen. So this is a difficult condition. I think only we dermatologists know it, but I'll still ask. There is a sign that is often asked in quizzes. This was in the upper limb. It's called the groove sign. Groove sign with stony, hard legs, limbs, and everything. So this is a fibrotic condition called eosinophilic fasciitis. Eosinophilic fasciitis. Eosinophilic fasciitis or Schulman syndrome. Ma'am, you mentioned about the syndromes. So this is a syndrome which is not very dangerous because you don't have much internal unlike scleroderma. If you see so much of hardening, you also think about scleroderma. So this is a pseudo-scleroderma condition where you don't have the lung manifestations or the kidney issues or any of the other systemic manifestations, but there is a fibrotic process going on. There is deep-seated fibrotic process going on, and that actually pulls, and you can see that the vessels which are going, they are also pulled down, which is why you get the groove sign. So when you see so much of stony, hard limbs, you could also look at the groove sign where your vessels are pulled down. But ultimately, when in doubt, refer and go for a biopsy. Biopsy gives you the classical, histopathology gives you the classical findings. But otherwise, it might be sometimes confusing. So anyway, this is eosinophilic fasciitis, which can also present like a red swollen leg. Now, have you come across this condition called livedoid vasculopathy? Livedoid vasculopathy or purple syndrome. This is also quite common because it's a mimicker of vasculitis. So there are 3 stages for livedoid vasculopathy, where the first stage is called livedo reticularis. Livedo reticularis you must have heard, right? In PAN and all, you get in polyarthritis nodosa, you get that lacy net-like pattern of erythema. Lacy net-like erythema. That's called livedoid reticularis. That is the first stage, followed by the second stage, which is the ulcer stage, and the third stage, which is atrophia blanche. Have you heard about atrophia blanche? This is the third stage. You can see the porcelain atrophic scars here. Porcelain white they are. And they are actually surrounded by stellate hypopigmentation and erythema. This is classical of a vasculopathy. What is a vasculopathy? In vasculopathy, basically you're having the small vessels are plugged. There is a microthrombotic process happening. And this is not a proper vasculitis. Proper vasculitis, we know we have the named vasculitis, you have the Chapel-Hill classification, large vessel, medium vessel, small vessel and all that, where there is inflammatory process destroying the vessels. Here it's just a vasculopathy where you have the small vessels which are plugged by the thrombotic, microthrombi. So that is the vasculopathy. I think vasculitis versus vasculopathy itself is a separate topic altogether. But this again is not an uncommon presentation. Livedoid vasculopathy, where you get these classical. So many of your patients might come with varicosities and they might have these associations. So many of the leg ulcers that you see are mixed etiology ulcers. You have arterial, you have venous, and you have these vasculopathy and vasculitis also coming into the picture. So in a nutshell, when you get somebody with a red leg, you have acute and inflammatory causes, and you also have chronic causes. Acute and inflammatory causes, we often think about cellulitis, but sometimes it could be even a contact dermatitis. Sometimes it can be, cutaneous vasculitis. It can be erythema nodosum. Erythema nodosum, you all know, right? Erythema nodosum can be, you get tender nodules on the shins. And they are actually, it could be a marker of tuberculosis, sarcoidosis, inflammatory bowel disease, other connective tissue disorders, so many things. So when you get acute red leg, these are the things that you should think about. Now coming to chronic red leg. A person is having red leg since a long time. You think about stasis dermatitis. Stasis dermatitis is because of venous stasis. You get, because of the, slowing of the circulation, you get eczematous reactions around the ankle. Usually the medial malleolus, also the lateral malleolus. And when it progresses, you actually get fibrosis and hemosiderin deposition, and you get lipodermatosclerosis. And of course, necrobiosis lipoidica. I think I heard the term first in Harrison only. Harrison mentions beautifully about necrobiosis lipoidica diabeticorum. Though we don't see that much in our population, or we might be missing it. You get orangish plaques with central atrophy on the shins. That is a typical classical description of necrobiosis lipoidica diabeticorum. And of course, we cannot miss out our pretibial myxedema. Pretibial myxedema, the difference here is that in lipodermatosclerosis, it is circumferential. The whole circumference of the leg is involved, whereas in pretibial myxedema, it's only the anterior aspect. And of course, you have the other one, there is venous stasis, and the other you have thyroid disorder and things like that. So these are the differential diagnosis, and most of them are bilateral. Lymphedema can sometimes be unilateral, and in lymphedema, you have the classical stemmer sign. What is the stemmer sign? You try to pinch a fold between the first toe and the second toe. You're not able to pinch a fold because it is so edematous. So that is called the stemmer sign, which is classically seen in lymphedema. And DVT can also be a mimic sometimes, and you might confuse DVT with cellulitis. We all know that. I mean, you know better than me. So this is in a nutshell. Now we go on to the classic dermatological conundrum, which is the maculopapular rash. So maculopapular rash, whenever this is our dermatology consult, we get daily dermatology consults from our physician colleagues saying that 30-year-old who started on antibiotics since 5 days developed this generalized rash. Now you comment, what is it? Is it an infection? Is it a viral rash? It is a drug rash? Yes. The only problem is it's not so easy because it's a mix, right? So this is probably a viral. And so infection versus drug, it's not a diagnosis, it's a puzzle. So you need to actually you make out and try to solve the puzzle, and the answer often lies in a careful history. So many pointers you have to ask regarding the evolution, the drug history, the temporal correlation, the nature of the rash. So this is classic textbook teaching. This is what we teach our postgraduates, viral versus drug. So in viral, you get prodromal features. It'll be there, right? There'll be fever, there might be conjunctivitis, rhinorrhea, myalgia, arthralgia. In a drug rash, generally not seen, right? And the evolution of the rash. The drug rash is often pruritic. If you have DRESS syndrome and all that, it's highly pruritic. Whereas a typical viral rash can be pruritic, but not so pruritic. So that is also one thing that you often notice. And the viral rash the drug rash often have the face involvement, but in children you also have infections also where like your erythema infectiosum or all those things you have facial involvement. Distribution, there is usually a progression as far as viral is concerned. You generally have a cephalocaudal progression, whereas you don't see any such progression in case of a drug rash. It's mostly trunk, or there is an acral predominance. It's mostly seen on the hands, and there is an acral predominance for the drug rash. And of course, the temporal correlation. In viral, you don't see the you don't see any correlation with the drug as such, but in the drug, yes, of course, you see it after the 7 to 10 days of intake or even earlier, and improves on withdrawal. And when you give the drug again, that is when you re-challenge again, there can be reoccurrence of the rash. And you also look at the blood parameters. Eosinophilia can be a sign in favor of drug rash, but it's not always pathognomonic. And if you have DRESS syndrome kind of thing, you have to look at transaminitis and things like that. Transaminitis might be there, and other leukocytosis and other parameters might be deranged when you have the drug rash with eosinophilia. That's a different kind of drug rash, not the usual drug rash. I think I'll take it up later. So these are in, simple pointers, viral versus drug. In viral, there is a progression. In drug, there is no progression, but mostly acral predominant. And drug is generally very pruritic. Viral is usually non-pruritic. And prodromal features are seen in viral, not so much in drug. And eosinophilia can be a pointer more towards the drug. So that's another thing we need to remember is in the named viral fevers, like you have Koplik spots and measles. Where do you see Koplik spots? In the buccal mucosa opposite the first and second molars. And you might see the spots in the soft palate in case of rubella. And I don't think you're bothered about roseola infantum because I don't think you get to see, but you see the classical Nagayama spots in roseola infantum. But the problem is all these spots might have disappeared by the time the rash is evolved. These are early features, so it's not necessary that you see the enanthems. But when you're suspecting a viral rash, please do look for the enanthems because these are clinical signs which we shouldn't miss. And you have the Pastias lines and scarlet fever. So many classical teachings are there. So these are things which you could look at. Also look for lymphadenopathy. You know, IMN has a classical type of lymphadenopathy. Even in dress, you have lymphadenopathy. So you do look at that. And then generalized maculopapular eruption occurring after ampicillin. So that is neither drug rash nor it's probably IMN related. We know that particular situation. And dress again is something, the triad of fever, rash, and lymphadenopathy, and a long incubation. In DHS or dress, what usually happens is the patient has had an history of intake of a drug a month back or 6 weeks back. So they often do not come out with the history. They generally associate a drug rash when it is immediate. Within a week, they'll tell you, okay, I took this antibiotic, I took this drug. But when the drug intake happened a month earlier, they have been initiated on carbamazepine or phenytoin 1 month earlier, then they would not tell you the history unless you ask. So the problem with dress is it's often missed because of the long latency between the initiation of the drug and the development of the rash. Dress is a condition where the latency is long. It happens in a month's time. So that again something you should not miss, particularly when the drugs are of the anticonvulsant group. I think I'll take that up later also. And we spoke about blood eosinophilia as well. I don't know if it's very clear, but the palmar lesions particularly, if you look at it carefully, this can be almost a spotter. Young sexually active male presenting with this rash of 10 days duration. Generalized non-itchy rash, including palms and soles of 10 days. It is secondary syphilis. It is secondary syphilis. You get the typical, it looks almost like a pityriasis rosea. PR like rash, you get the collarate scaling and all that. That is why our teachers used to always tell us, the moment you diagnose a PR, don't stop, send a VDRL. Don't stop there. You send a VDRL because often you might be surprised. Nowadays, we don't see so much of secondary syphilis. We do still see, it's not so uncommon also, and we see a lot of paper syphilis also. The patient is going abroad, they do VDRL, it is positive. DHT, don't they come to you also? So that we see it's not so uncommon. So syphilis should not be given an obituary so early. So we do see secondary syphilis and ask. And history, they might not always give you the history of sexual activity or genital ulcer, which is often missed. But a rash like this, don't look, a maculopapular rash of short duration, pityriaciform in nature. Don't forget to look at the palms and soles. You get the typical collarate-like annular scaling there. So that is syphilitic corny. Have you heard about syphilitic corny is what it's called on the palms and soles. Yeah, so this patient also had a low-grade fever and generalized lymphadenopathy. Secondary syphilis should not be missed in maculopapular. Also in HIV, you get similar rash. Seroconversion, you get rash. So these are things we should have in our mind. So this is a young female who presented with these erythematous scaly rash on the back, also on the forearms, upper part of chest since 8 weeks. Any differential diagnosis? Annular almost. Rash is annular. You can see that it's almost ring shaped, right? You have that scaling, but it's non-itchy. No itching is there. I'll give you one more clue. There is photosensitivity. Young female. Young female with a photosensitive rash, annular, erythematous scaly. This is UV induced, but it's a systemic disease which you treat more than me. It is SCLE. It is subacute cutaneous, it's classical SCLE. Subacute cutaneous lupus erythematosus. The malar rash that we know is ACLE. Like when you talk about cutaneous lupus, you have acute, you have subacute, you have chronic. Acute is what? Our malar rash. I'm talking about specific. You have non-specific cutaneous signs, let us leave it. But specific means you do a biopsy, you will find the actual features of lupus in the biopsy. So that is malar rash. And in acute cutaneous lupus, you also get sometimes a TEN-like rash or a generalized maculopapular rash. That is acute. Acute cutaneous lupus means there is definitely SLE. That's for sure. When you have subacute cutaneous lupus, that's called SCLE. You get annular psoriasiform lesions. So should not be missed. In a young female with photosensitivity, annular psoriasiform lesions, scaly papillosquamous lesions, it is classical. SCL is a DD, a differential diagnosis. And you should do an ANA because here also not 100%, but the chances of having SLE is very high, very high. So that is sometimes you also get erythema multiforme like lesions with SCL. That's called Ravel syndrome. So EM-like lesions with SLE, that is Ravel syndrome. So that is a subacute cutaneous lupus. You also have chronic cutaneous lupus, which is called DLE. You must have heard about DLE, right? Discoid lupus. Discoid lupus is why that name lupus itself came. You have that wolf-bitten-like appearance. Discoid lupus is characteristic. You have the atrophic plaques on the head and neck area. There is loss of hair. There is scarring alopecia. I didn't keep it because it's quite well known. DLE is well known. Chronic cutaneous. Subacute and malar rash is also well known. Most of you will look at the malar rash. But what is not so well known and should not be missed is subacute cutaneous, where you get psoriasiform lesions. So again, I think when you get a generalized maculopapular rash, you should think of it in these 5 headings. Infectious, whether it's viral or bacterial. Viral, you have the usual stuff, measles, rubella, dengue, COVID, all those things. You have bacterial. You in typhoid, you might get, not in very dark people, but yeah, you might get roseola or spots. Secondary syphilis, you should not miss. Drug induced, you should always consider. Antibiotics, anti-epileptics, NSAIDs are the commonest causes. Inflammatory, your classical PR, pityriasis rosea, psoriasis, that all these things can present with inflammatory maculopapular like rashes. Then of course, SLE, dermatomyositis, all these things are DDs. There are many more DDs, but at least these 5, infection, drug-induced, inflammatory, autoimmune, these should definitely be in our differential diagnosis list. So now after the red rash trap, we move on to the skin as marker of systemic disease. I think, again, I'll just do spotters here. This is a classic presentation. If you have any thoughts, you can tell me. Otherwise, I'll tell you an important comorbidity the patient has. You're seeing hyperpigmented papules, very itchy, very, very itchy. A diabetic patient, highly itchy. Most of your diabetic patients will at some point of time will come with this because it's very common. And this is not diabetic shin spots. These are not diabetic dermopathy. This is very itchy. Haven't you seen these itchy spots in uncontrolled diabetes particularly? This is called acquired perforating dermatosis. Acquired perforating now perforating dermatosis, you have the usual perforating dermatosis. I think that is more of we dermatologists, I don't know, our ancestor dermatologists, they used to love big terms. So they had kept very big terms for that. So I'm not going to the normal perforating dermatosis, which is Chiral's disease and things like that. But the acquired ones are generally secondary to diabetes or renal failure or hepatic failure. Secondary to that, in the skin, there is a transepidermal elimination of either elastin or collagen or follicular material, which causes an intense itchy rash. And why I put it here is because it's very common. We get a lot of consultations from our endocrinology departments and other departments with this highly itchy rash, and they think it's something. Sometimes they are diagnosed as lichen planus, because it has a lichenoid look. So it's very easily misdiagnosed as lichen planus. The other differential diagnosis would be a condition called prurigo nodularis, where they simply itch and they're labeled as, pruritic. But here the treatment is different. You of course have to treat the diabetes, and you also have to initiate the patient on retinoids. So that is why acquired perforating dermatosis is something which is worth knowing. It's very common in diabetic patients, especially uncontrolled diabetes. Okay. Now this though you know. What do we check? If you see this, you look at these are xantho. You see the yellowish plaques, the typical yellowish plaques. We've heard about the tuberous xanthomas. And these are xanthomatous lesions, xanthomas. So again, you have xanthelasma, that is around the eyelid. You have the xanthomas. You have the tuberous ones. Sometimes you get the tendinous ones. So of course, you look at the lipid profile. And this is nothing but acanthosis. And what is the connotation? We have to look at uncontrolled diabetes. If it's a female, you have to look at PCOS, metabolic syndrome, and things like that. So, and the other point is acanthosis nigricans can also be malignant acanthosis nigricans, where you get even mucosal involvement, and it can be rapidly progressive. That's how you should not miss it can be secondary to a malignancy also. So not only metabolic syndrome, diabetes and everything, you can also have it in malignancy. And what is this? Sudden eruption of seborrheic keratosis with itching. I think we had that sign in Bailey and Love, not in Harrison. Lesser Trillat sign. Lesser Trillat sign. Again, it's a marker of internal malignancy. It's a marker of internal, lesser Trillat sign. And like in acanthosis nigricans also, you have similar conditions on the palms called tried palms. That is also a marker of internal malignancy. This is also lesser, LESAR-TRELAT. Lesser Trillat sign is also a marker of internal malignancy. Not all seborrheic keratosis. Many of our patients elderly have this seborrheic keratosis lesions on the back here and all that. But all that is not lesser Trillat sign. So you should not tell them that they all have some malignancy. But the sudden eruptive appearance of many seborrheic keratosis like lesions with pruritus, eruptive seborrheic keratosis pruritus is a marker of, that means there are growth factors. So the body is producing growth factors from somewhere. So that's why we call it it's a paraneoplastic marker. Yeah, this I think we already talked about, erythema nodosum. It can be secondary to TB, sarcoidosis. We've heard about the Lofgren syndrome and the Hereford syndrome in sarcoidosis, right? So Lofgren, that EN stands for erythema nodosum. Sarcoidosis should not be missed in erythema nodosum. Similarly, tuberculosis. So that is something which we need to rule out. And of course, another DD for this would be erythema nodosum leprosum of leprosy. Leprosy, it's a type 2 reaction. Erythema nodosum leprosum. But the erythema nodosum, that plain erythema nodosum will occur only on the shins. Whereas erythema nodosum leprosum can occur anywhere on the body. And you have fever and, constitutional symptoms and all in ENL. Now, this is a case that turned out to be sarcoidosis. You have erythematous nodules. There's a condition called papular sarcoid. Papular sarcoidosis can sometimes present with, so these lesions look very pimple-like, right? But when in doubt, you should refer, and if, we did a biopsy, that's why that thing is there. So this turned out to be sarcoidosis. So you can get shiny erythematous nodules on the face. They can be leprosy. Our differential diagnosis were leprosy, sarcoid, histioid leprosy can present like this, and there are other, even certain tumid type of lupus. So many different, even lymphomas can sometimes. So when you see shiny nodules, not usually pimple, the consistency is more indurated. You should not just write it off. Especially if the patient is getting new lesions, do a biopsy and confirm. Now this is actually a surgical case, but more connotations for a physician. It is a pyoderma. You see undermined edges of the ulcer. You see this ulcer rapidly. This was a rapidly progressive ulcer with deep-seated pain. Highly painful it is. Highly painful. So this is nothing but pyoderma gangrenosum. Pyoderma gangrenosum. And the classical association of pyoderma gangrenosum is with ulcerative colitis. Yes, ulcerative colitis and Crohn's disease. So this is IBD associated pyoderma gangrenosum, and it often heals with the cribriform scarring. When it scars, it will leave behind a cribriform appearance. So that is pyoderma gangrenosum. This is a spotter. This is a spotter, a lady with a rash around the eye, violaceous rash around the eye, and you're also having the classical, along the tendon, you're having confluent macular violaceous erythema. Along the, you don't see the papules, but you see the erythema. So you're having erythema and edema around the eye, and you're also having similar lesions on the tendinous aspect and the elbows. So this is nothing but dermatomyositis. The heliotrope rash, the classical heliotrope rash. Heliotrope is a flower. That flower is, it's got that color. That's why it's called the heliotrope. Can you see the erythema and edema around the eyelid? And you're also seeing the confluent macular violaceous erythema, Gottrin's sign on the along the tendon. So that is dermatomyositis. So when you get dermatomyositis in an elderly, you always have to check out for malignancies, because dermatomyositis is often the harbinger of malignancy, especially CA ovary. We see a lot of patients presenting with dermatomyositis. You can't just label it dermatomyositis and leave it there. You have to do a PET scan, whatever, because they often are associated with malignancies, not only mere autoimmunity. And of course, you have other signs. If they're confluent, the similar confluent macular violaceous erythemas on the V area of the neck, it's highly photosensitive pruritic rash. They'll complain of severe itching in the photosensitive area. So you have the V sign, you have the shawl sign, and if it occurs on the thighs, you have the holster sign. So many signs are there. And you also get, when you look at the nail fold capillaries, you see dilated nail fold capillaries. You also sometimes see attenuation of capillaries and capillary drops. Now, this is a case which recently came to us. Just to tell you regarding this, turned out to be, we thought it was some B-cell lymphoma. Then we were thinking he was a farmer, so we thought it was, it could be some tuberculosis like, but it didn't fit the classical tuberculate like appearance. We thought it could be some kind of sarcoid. We thought so many things. Mainly we were thinking histoplasm, all exotic infections we were thinking. But if you look closely, I haven't put the close-up, there is some yellowish color in the center of those nodules. He didn't have anything else. It turned out to be a condition called Rossi-Dorfman disease. I don't know if you've heard about it. Rossi-Dorfman disease. It's a condition where you get massive lymphadenopathy, and it's a non-Langerhans histiocytosis. You heard about histiocytosis, right? Like Langerhans histiocytosis. It's a kind of non-Langer. So sometimes we come across such rare conditions also. Just kept it there, not. And so when we talk about system-based skin manifestations, you have all these conditions like cardiac. You have infective endocarditis, and look at the Janeway lesions, Osler's nodes, splinter hemorrhages and all that. Renal, you have uremic frost, you have the classical the end-stage renal failure patients, all the dialysis patients, they complain of incessant pruritus. It's very difficult to treat their pruritus because of dry skin and so many other things. Then thyroid disease, you get pretibial myxedema, the hair lacks and skin lacks the luster and everything. Diabetes, I think we already talked about. Liver, you get palmar erythema, you get spider angiomas and things like that. Hematological conditions, you get petechiae, purpura, ecchymosis. Autoimmune, we already talked about the malar rash, the Gottrin's papules and all that. Malignancy, we talked about the sudden seborrheic, the lesser Trelat's sign. And also dermatomyositis can be a marker of mal. There is so much more, but in a nutshell, these are the things which we should consider. Now I'm going to talk about a group of conditions which are dangerous, and they often come to you. They don't come to us. They usually come to you. So these should not be missed. Now this, I'm sure you all would have come across. Young male had head injury following a road traffic accident, underwent decompression 8 weeks back and developed this rash. What is this rash? They land up in our emergencies. Usually must have been managed by local hospitals a lot, and then they land up in a casualty, in an emergency department of a bigger hospital. And this is how it usually looks like. This is nothing but toxic epidermal necrolysis. This is not SJS. This is not Stevens-Johnson. Stevens-Johnson is less than 10%. You have mainly mucosal manifestations like oral cavity and eye. You don't get this much of bulla, this much of skin necrosis. More than 30% is TEN. This is not 30%, this is much more. Thankfully, this patient survived. It's not EC2 because 30% mortality in TEN. So, and they won't tell you the drug history, that's the main problem. But this is the history you get. Head injury, decompression. So what is the inference? Head injury, decompression means definitely the neurosurgeon would have given anticonvulsants. So it is our job to ferret out the history. So this patient had carbamazepine. Carbamazepine induced TEN. So if you don't stop carbamazepine and you don't, no matter whatever you do, the patient is not going to survive. The first treatment in a suspected drug rash is stop the drug. Identify the drug and stop the drug. And the problem here again is the TEN also, the latency is 2 weeks. It's not immediate. So you often miss. What happens is that the patient would have had this rash, and then they go to a local, and a fever or something might be there, throat, sore throat, red eye. That local doctor will give an antibiotic. Some amoxicillin, something will be given. And the blame will fall on what? The blame will fall on amoxicillin, poor amoxicillin. It is not amoxicillin, it is the previous carbamazepine or phenytoin which has done the work. Or sometimes somebody would have started sulfasalazine. They would have started sulfasalazine for rheumatoid arthritis. Sulfa anticonvulsants, very, very, very common. And the latency is long. So ask for history up to 1 month. Don't stop it 1 week or something like that. So TEN is it's a emergency, should not be missed. It's the mortality is very high. So this patient was given IVIG and steroids and recovered time. And you need a lot of multidisciplinary care, lot of dressings, antisepsis, ICU, everything. Right? So this is another, not my case, this is a picture which I took because I didn't have a proper picture to show you. Now this is a patient who presented with this rash after initiating sulfasalzine for rheumatoid arthritis. Here you are not seeing necrosis. You're not seeing bulla. You're not seeing mucosal involvement. What you're seeing is a maculopapular rash with facial puffiness. This is DRESS. This is DRESS syndrome, or called DHS, drug rash with eosinophilia and skin symptoms, that systemic symptoms, or it is also called DHS. I don't know which name is more familiar. It's a type of drug reaction which is also fatal if it is not recognized on time. So there in TEN, the problem was what? There was skin necrosis. So it acts like a burn. If the whole skin goes, then naturally the patient will die, because just like a burn, 50%, 60% burn, the patient will die because of necrosis and all the complications that will happen later, like respiratory sepsis and things like that. Here the problem is in drug rash with eosinophilia and systemic symptoms, in DRESS or DHS, there is organ involvement. It's a systemic syndrome. The drug acts like a haptin and it triggers a systemic inflammation. There is systemic, all the inflammatory markers will be elevated. There will be leukocytosis. There will be transaminitis. It can go on to liver failure. So here there is a systemic response to the drug. And the feature is facial puffiness. So if you're seeing a rash with a history of anticonvulsant use or epileptic use or sulfa use or things like that with facial puffiness, please think that this could be DRESS. And there will be eosinophilia. That is why the name itself has DRESS. So these things are what I wanted to highlight, the drug part especially, because even if one patient we can identify earlier, many of you would be seeing many patients. So if at least one patient we can identify earlier, that would make a lot of difference in those patients. So these are the causes. So normal drug rash is there, and there are drugs which can cause serious reactions, which we call SCARs, severe cutaneous adverse reactions. So in that comes your allopurinol, all your all anticonvulsants, mainly the aromatic anticonvulsants, that is phenytoin, carbamazepine, phenobarbital. So you have to substitute with a different drug. So that is the thing, and of course NSAIDs and things like that, and you have to take a long history, a full history, complete medication list, even topical. I've had a patient who had SJS following ciprofloxacin eye drops. So those things are also, don't miss out those as well. Viral infections. The problem with viral infections is human herpes virus infections can actually cause this. They actually interact with the drugs and the body and create more of a drug rash. They actually predispose you to create more of drug rash because of the inflammatory. They have a synergistic action, the drug and the virus. So things like that. There's another condition where we get ICU consults called purpura fulminans. This is another dangerous condition. And you have widespread microvascular thrombosis and necrosis. I just wanted to put it here. In ICUs, patient with sepsis, end-stage sepsis, you get these purpuric rash. It is not vasculitis. It is nothing. It is no warfarin necrosis. It is nothing but purpura fulminans, where there is thrombosis because of the sepsis. Now the last part is common conditions. Now we talked about all a little bit hi-fi conditions. Now we are talking about common conditions, but which are commonly mismanaged. One is herpes zoster. Herpes zoster, if you don't look at the skin, you don't examine the patient, it's often, sometimes the patient ends up in the cath lab for an angiogram, right? Because it is a mimic, because thoracic dermatome, and if it's on the left side, we've had 3 cases where we have had calls from the cath lab that this patient is posted for angioplasty, but they are having skin lesions. It's nothing but herpes zoster. The pain of herpes can be so bad that it can mimic an it can mimic an angina, and so that's something you have to examine the patient, right? And yeah, so it can evolve, and sometimes initial lesions can be subtle, and then it classically progress towards the dermatome. Grouped vesicles are the characteristic of herpes zoster. Grouped vesicles, and the pain is typical. Now, this is another condition which we dermatologists, I mean, I'm sure you also get it. The left side is vitiligo, actual vitiligo. The second one is not vitiligo. It is a common condition we see in elderly called idiopathic guttate hypomelanosis or IGH. It is just a degenerative condition. You get white spot, vattam, pottu pottu pole. Alland vitiligo pole, it will not come everywhere. So you just have to reassure the patient saying it's an age-related degenerative condition, and that is IGH. Now, these are two conditions. On the left side, you see patchy hair loss. This is usually what we call alopecia areata, which is a common autoimmune type of hair loss. The second one, on the right side, what you're seeing is not alopecia areata, though it's also patchy. It is nothing but trichotillomania. What is trichotillomania? You're pulling out your hair. It's a little bit patients who are anxious. They have a little psychiatric or psychological instability. They might have this urge to pull out their hair when they feel stressed. How do you differentiate? Trichotillomania is usually seen in areas where it's accessible. So it's the parietal areas. And when you examine, you see capillary hemorrhages. You see reddish spots because of the trauma of pulling hair. And you also see hairs of various length because they're pulling out at different phases now. In alopecia areata, you'll see bald patch. You don't see hairs of various lengths. So these are clinical pointers in trichotillomania. Now, this is again intertrigo or flexural psoriasis is often confused with the tinea cruris. So again, that's something which we need. If the fold is involved, it is more likely to be flexural psoriasis or intertrigo and not tinea cruris. Now, here you have three conditions. On the left, what you have is, that appearance is quite classical. It's neurofibroma. Neurofibroma. Similar, but on the center, what you have is molluscum contagiosum. Neurofibroma, you have soft, fleshy. Once you see it, it's classical neurofibroma. On the middle, you have molluscum contagiosum. You see, you have dome-shaped papules, pink dome-shaped papules with umbilication, meaning you have a central opening. And on this side, what you have is leprosy. So, can look very similar. So, if in doubt, you need to do a biopsy also. And scabies, on the right, what you have is scabies. Scabies, again, where does it present? It presents in the web spaces with intense itching. And intense itching, nocturnal exacerbation of itching, that is classical scabies. On the left, what you're having is atopic dermatitis, usual hand eczema. So again, this can be confusing. And another problem that we all, a mistake that we commit is we don't examine the patient without clothes. That's web space involvement. This is left, that is right. Your left I'm talking about, and mine too, because I'm also towards them. So this was treated, I don't know if you can see, but an annular lesion on the flexor aspect of the wrist. And you don't know, this could be a tinea because it's round, it could be something else, it could be an eczema, like a nummular eczema. Nummular eczema is also round. But when you unclothe the patient, what do you see? Now there is no confusion, right? Widespread tinea cruris. I think still there is some issue with the light. You're not seeing the pointer. Yeah, but this doesn't need a pointer. Yeah, but this doesn't need a pointer, sir. This is it. But still, because of the flash, I think that resolution is not clear. Yeah. So this is the initial rash, but when you unclothe the patient, what you see is the tinea cruris, the proper tinea cruris. Now this is, again, sometimes you might think this is tinea cruris or tinea corporis, but what is this? This is contact dermatitis. Contact dermatitis to what? To nickel. All those steel colored things, the safety pins, the hooks, the brass straps, all those are nickel. And you can see that this is the area where the hook comes, see? So here again she is getting, so unless you see it with the picture like this, you won't be able to make out. This is a contact dermatitis. So these are very interesting for us, like detective work. Again, this is something which we often think it is tinea cruris. But what is this? This is again contact dermatitis to nickel. This is the area where the holder comes. So that's again contact dermatitis to nickel. And when the patient was asked to avoid, there was complete resolution of lesions without any other treatment. So identifying that becomes very, very important. So some detective work again. And this also, I've already put the diagnosis. But sometimes they go around for this rash everywhere. This is because this lady washes her clothes and puts the water onto the legs, and she has that anklet, so that thing accumulates there. Similarly with the ring. So this is nothing but detergent contact dermatitis. Similarly around the bangles, detergent contact dermatitis. So there's no point treating unless you identify this and ask them to make the lifestyle change, because otherwise it will keep recurring. No point giving them topical steroids. Now, another important differentiation is between SJS and FD. SJS is something that looks like this. Okay, earlier stages you can get erythema and no. I think, yeah. This is FD. That actually a tinea came in between. This is classical fixed drug eruption. Fixed drug eruption. This you see, even if the patient tells you, I did not take any drug, I tell the patient, this is fixed drug eruption. This cannot be anything else. This appearance has no other differential diagnosis. There can be something called fixed food eruption also. But then they go back and tell me that, yes, I took one paracetamol tablet, day before yesterday, I forgot. I took some cough syrup. So fixed drug eruption, you have this central necrosis, almost dilation with that ring-like erythema. That ring-like erythema, can you see? And you get bullous FD also. And sometimes you get them on the mucocutaneous junction between the lip and the skin. So the classical site are lip and the skin, then the trunk, and also the penile, dorsal aspect of the penile shaft. So these are classical sites of FD. And what are the common drugs causing FD, fixed drug eruption? It can be antibiotics, it can be painkillers, it can be pseudoephedrine containing, especially they can cause a pigmented FD. The problem with fixed drug eruption is it leaves behind a nasty pigmentation, which will take a long time to go. So and every time they take the drug, they keep getting it again. That history is also classic. They don't usually come to you on the first visit. They come to you with a recurrent history of unexplained lesions like this popping up on various aspects. So that is FD, fixed drug eruption. There's another drug rash called the AGEP, acute generalized exanthematous pustulosis, where 24 hours after onset of an antibiotic, which is macrolide or a beta-lactam, you get this kind of a rash. The closest DD to AGEP is pustula psoriasis. It's very difficult. They are almost allelic, so you can't really differentiate between an AGEP and a pustula. It's almost impossible to differentiate. So the drug history becomes very important. Okay. So that is, and often it's mistaken as every time you see pustules, you think it's an infection. But AGEP and pustular psoriasis are not infections, and you should not treat them with antibiotics. The inflammatory markers will be elevated, CRP will be elevated, everything will be, even procal may be elevated. And often our physician colleagues tell us to start whole high-fi antibiotics, but these are conditions where antibiotics may not be required. And so coming to the last part, this is what I wanted to highlight about topical steroid misuse. So when in doubt, the common tendency to prescribe topical steroids. So you have so many things, and people also apply so many things for the face. Now even beauty parlor people are giving topical steroid containing preparations for face. So as physicians, our first duty is do no harm. So unless you are very sure what you are treating with, please don't use topical. There are so much, and we are having an epidemic of tinea, resistant tinea, because of the combination. You have quadrid, you have so many combinations. You have neomycin, steroid, antibiotics are usually used when we don't know what we are dealing with. So if you're sure what you're dealing with, you don't need to mix. What is the indication of mixing a steroid and antibiotic or an anti? There is no indication. So those mixture combinations should be avoided, and yeah. So that's what a word once said, an arrow that's set to go, a steroid cream containing prescription. They keep you, like you have Zolef, like people are using it for years together. Somebody gave it to them 20 years back. And this is what they end up with, especially in their crural areas. So this is something I wanted to highlight. And on the face, this is what they end up with, steroid cream containing preparation. So with that, I know that I did overload you, but that was my brief, and thank you very much for patient listening.